Hello, I'm Dr. Maury Markman from City of Hope, and I want to discuss this session and the next couple of sessions a topic that actually shouldn't be controversial, but on some occasions, as we'll discuss, it is, and that's the topic of clinical cancer trials. Now, clearly, we all know, and there's really no debate, as far as I'm aware, that the foundation of modern cancer medicine, the foundation of the optimal treatment we provide our patients is based on data from well-designed, conducted, reviewed, and then reported clinical trials, reported in the peer-reviewed medical literature. Think about my own area of clinical interest and research, ovarian cancer. Thinking about when I began my own professional journey, we were using combination alkylating agents. Prior to that, we actually just used single alkylating agents. And then, of course, we had platinum, cisplatin, which all its toxicity revolutionized the treatment, not only of ovarian cancer, but other cancers. And then trial data demonstrated that we could do just as well from the point of view of efficacy with less toxicity with carboplatin. Then we had paclitaxel, and then bevacizumab, PARP inhibitors, et cetera. Without clinical trials to define optimal care, I can't even imagine where we would be, both in terms of efficacy and quality of life for our patients. Very little controversy, any about that. However, the area of clinical cancer research has increasingly recognized the issues with clinical trials, and it really relates to the fundamental question of the representation of patients we actually see in the non-investigative setting in clinical trials, so-called real-world patient population versus the trial population. We're talking about spectacular and very distressing underrepresentation, which many are working on, but still underrepresentation of the elderly, majority of patients who have cancer, various ethnic groups, socioeconomic groups, and critically, individuals with common comorbidities, cardiac, pulmonary, renal, that occur in the population routinely, particularly in the elderly population. Patients who might literally be excluded from the trials, either directly excluded, you can't admit it, or because of concerns, patients aren't admitted. And therefore, the question is, when you have the trial data, what does it mean? How does it represent the population that I'm seeing in my practice? Or as a patient or as a family member, the question then comes up, what are the toxicities potentially to be experienced, the potential benefit when patients like me with my background were not in the trials or were very much underrepresented? We also have recent data to demonstrate just how there's a lack of geographical distribution of trials. One study demonstrated that 70% of counties in the United States are without any reported cancer clinical trials. That represents almost 20% of all individuals in the country who are 55 years or older. And in fact, 86% of non-metropolitan areas defined by the authors in the paper had no clinical trials. And very importantly, 26% of individuals who are 55 years or older live more than an hour drive from a site where there were more than 100 studies. Why more studies? Well, the more likelihood that there will be a trial relevant to that patient, that disease, that stage of disease. 26%, 1 out of 4, live more than an hour away. And think about the time and effort that goes into a trials, how difficult that is. So these are issues that need to be dealt with. Certainly from a societal perspective, it's important over time we fix these issues. But there are other things that we need to consider. And the question that I'm going to address next time is a very provocative question, which is, why should patients participate in clinical trials? What is the benefit to them? I look forward to our next conversation.